Hemorrhoids, commonly known as piles, are the most common problem affecting the anorectal region. Patients may feel embarrassed discussing symptoms, so sensitivity is important. The exam tests the underlying anatomy, classification system, clinical features, and referral criteria. The cause of hemorrhoids is probably multifactorial, with anatomical, physiological, and mechanical processes implicated. The traditional description as engorged veins of the hemorrhoidal plexus, with the analogy of varicose veins of the anal canal, is actually misleading. Current thinking favors the theory of prolapsed anal cushions. Anal cushions maintain fine continence and are submucosal vascular structures suspended in the canal by a connective tissue framework derived from the internal anal sphincter and longitudinal muscle. Within each of the three cushions is a venous plexus fed by an arteriovenous blood supply. Veins in these cushions fill with blood when sphincters relax and empty when they contract. Fragmentation of the connective tissue supporting the cushions leads to their descent. The prolapsed anal cushion has impaired venous return, resulting in venous stasis and inflammation of the cushion's epithelium. The anatomical classification is important. There is an area known as the dentate line, superior to the anal sphincter. At this junction, epithelial cells change from squamous to columnar epithelial tissue. Above the dentate line, hemorrhoids are classified as internal. Below the dentate line, they are classified as external. Internal hemorrhoids are further graded according to severity. Grade 1 hemorrhoids do not prolapse out of the anal canal. Grade 2 prolapse on defecation, but reduce spontaneously. Grade 3 require manual reduction. Grade 4 cannot be reduced. This grading system is commonly tested. The clinical features depend on the severity and type. Bright red painless rectal bleeding is the most common symptom. Blood is usually seen as spotting around the toilet, streaking on toilet tissue, or visible on the surface of the stool. Itching and irritation are also commonly observed. Symptoms are often intermittent, with each episode lasting a few days to a few weeks. Internal hemorrhoids are rarely painful, whereas external hemorrhoids can cause pain due to the cushion becoming thrombosed. Pain is described as a dull ache that increases in severity when the patient defecates, leading patients to ignore the urge to defecate. This can then cause constipation, which further worsens the cycle. The most common cause of rectal bleeding seen in community pharmacy is hemorrhoids. Anal fissure is likely. Ulcerative colitis and Crohn's disease are unlikely. Upper GI bleeds, colorectal and anal cancers, and diverticulitis are very unlikely. For differential diagnosis, several features help. Duration is relevant. Patients with long-standing symptoms not previously seen by a GP should be referred. Symptoms constantly present for more than 3 weeks should be referred. Pain characteristics help distinguish conditions. A dull ache that occurs on defecation and at other times, such as when sitting, is typical of hemorrhoids. Sharp or stabbing pain at the time of defecation suggests an anal fissure or tear rather than hemorrhoids. Rectal bleeding characteristics are critical. Bright red blood on the surface of the stool, on toilet tissue, or in the toilet bowl is consistent with hemorrhoids. However, blood mixed within the stool must be referred to eliminate a GI bleed. Large volumes of blood, or blood loss not associated with defecation, must be referred to eliminate possible carcinoma. The referral red flags include persistent or marked change in bowel habit in patients over 40, or unexplained rectal bleeding, which suggests sinister pathology requiring urgent referral. Blood mixed within the stool raises suspicion of inflammatory bowel disease. Fever is not typical of hemorrhoids and suggests an alternative diagnosis. Patients who need to manually reduce their hemorrhoids, grade 3 or above, are unlikely to benefit from OTC treatments and should be referred. Severe pain associated with defecation may indicate an anal fissure. A dietary connection is important. Lack of dietary fiber leading to constipation is a contributory factor. Hard stools and straining during defecation can cause hemorrhoids. Good practice dictates that people under 20 years suspected of hemorrhoids should be referred.
This video was brought to you by Pharmacy Skills. If you enjoyed this video and want to see more like it, Pharmacy Skills offers a comprehensive animated learning library covering the BNF, MEP, and general pharmacy training. Each video also includes practice questions and a range of revision tools to help support your learning. Visit us at www.pharmacyskills.com.